Hi, everyone. Welcome to the webinar. My name is Wendy Webster Coakley. I am a member of the class of 1985, and I oversee alumni career networking for the college. And now it's my pleasure to introduce today's presenter, Diane Shannon, MD, MPH, PCC, author, speaker, physician coach, and my classmate. We're going to be posting a link to Diane's website at the end of this presentation. So in the interest of time, I'm not going to read her whole bio, but I thought I would share a few key aspects about her Williams experience, things we all can relate to. Starting with her first year entry, which was layman. And for you young ones out there, layman was indeed a first year housing back in the day. Her major was biology, so shout out to all the bio majors out there. Her favorite thing to do outside of class or outside of lab was broomball. Love it. And her go-to snack bar order, cheese melt on pita, which I am suddenly craving. So Diane, I am going to yield the floor to you, and I will come back and see you at the end for the Q&A.
Thank you so much, Wendy. It is a real pleasure to be here tonight to speak with Williams alums. I feel like I'm with my tribe. And I wanted to share one of the things I'm so grateful for in my Williams education is that when I pivoted, moving from physician to writer, which I did about 25 years ago when I burned out from medicine, it was an easy transition. I had learned how to write. I had learned how to think critically. And I am so incredibly grateful for that. So tonight, I want to share a little bit about what I have learned about the challenges that women physicians and other clinicians face, and also what we can do about it, both individuals and organizations. And why is this important? Well, I'll just give you one piece of data at this point. 117,000 physicians left the workforce last year alone. And as we have more and more women entering medicine, so now more than 50% of medical school matriculants are women, and yet they tend to leave and experience burnout at higher rates. So this is really becoming a critical issue. So let me start with sharing my slides. Take me just a second to get things up here. Great. So again, I believe this is important, and it's something I'm incredibly passionate about, in part because of my experience. I experienced pretty severe burnout during training, but just pushed myself to keep going, practiced for a few years. But when I looked ahead, I didn't see a way that I wouldn't experience burnout again and again and again. And this was before there was much discussion on clinician wellness. We didn't know about burnout. I had never seen the word. And so that's when I made that transition into writing. I was a healthcare freelance writer for 20 years. And 5 years ago, transitioned into coaching. So I run a coaching company for women in medicine. And this is something I'm passionate about because of my personal experience and also what I have observed, especially as a writer looking at the issues in our healthcare system and how those affect physicians, and also as a coach in these one-on-one conversations with clinicians and hearing what the challenges are and what they're struggling with and the impact on them and their patients. So to get started, what I want to do today is explain a little bit about burnout and why there is this discrepancy between gender rates. Also, where do the gender role expectations fit in here? Where are they underneath the surface driving some of these rates? And also, I want to talk about some strategies to address them. As a disclosure, I have two businesses. I am the only employee of each one, but wanted to disclose that. Moving on to definitions. First of all, I'm speaking about women in an inclusive term, as an inclusive term, so whoever identifies as a woman. I'm often talking about physicians, because that is where most of the data is. That's my experience. But burnout affects pretty much everyone in healthcare and many outside in other industries as well. And so I want to just acknowledge that. And that when I'm speaking of women in medicine, mostly I'm speaking about the clinicians, so physicians, nurse practitioners, physician assistants, nurse midwives. But again, this affects others in healthcare. The stressors are a little bit different depending on the roles and responsibilities. I also want to acknowledge that while gender is one aspect of the challenges that can be layered on top of the stresses that clinicians experience today, there's also other layers of challenges. So this is where race and ethnicity in terms of bias come in, sexual orientation. So when there are those other biases and challenges that people face in the workplace, those get layered on top. And so there's that additional stress that goes along with that. Looking at the numbers, so this is data from just at the beginning of the pandemic. And as you can see, there's a statistically significant difference between the burnout rates among physicians based on gender. This has been true for pretty much as long as this has been measured. But what I noticed was that the disparity in gender in burnout rates for physicians increased as the pandemic began. And I became really curious about this. I wanted to understand what is going on. Now, in addition to the data that I gave at the beginning about, there are more than half of the medical students or matriculants are women, there's also this issue because within the first 6 years of training, one study found that 40% of women had either cut back from full-time or left practice. So 40% of those just 6 years out of training had cut back or left. And in that study, there were no male trainees who had left at that point. So we are looking at an attrition rate that is much higher as well. So why is this going on? What's underneath these numbers? And it can be easy to jump at one cause, but really it's complex. There's more going on underneath the surface. And that's why I think this is actually kind of fascinating. So what I did when I started to see that disparity increase, I thought, I want to understand this. This was at the beginning of the pandemic. And what I did was I decided I was going to interview a few women physicians. I started with 3. I thought that's a good number. I'll just get a little bit of information. It was so interesting. I ended up interviewing 30 across the country, different fields, different age categories. And I wrote up a white paper, which is available on my website if you'd like to read more. Now, this is what they identified as their top challenges. And you can see that some of them are external, right? They're the larger factors at play. So things like sexism, bias, motherhood penalty, which is where where women who are mothers may be looked over or stepped over in terms of a promotion or a special project because there's an assumption that they're not going to be as committed or they won't have the time or energy. Other kind of external factors list their productivity pressure. So that is the pressure on clinicians to work harder, work faster, see more patients, less time for each visit. And that has definitely increased over the past 5 years. There is a tremendous kind of targeting of certain number of relative value units that you need to produce in order to hit your number to make your salary, or hear about it from administration. Other of the challenges that they identified are internal, the guilt. They often talked about the guilt between, if you are a parent, the guilt that you want to be with your child, and yet you're pulled to be with work. And when you're at work, you're feeling like you should be at home. And when you're at home, you feel like you should be working more. Also, self-doubt and imposter syndrome was something they mentioned, and perfectionism. Perfectionism, being detail-oriented is incredibly important in healthcare, but there are places where we can go down rabbit holes where it's not clinically relevant. So that's the piece where the perfectionism comes in. Some quotes from these interviews. This one I thought was interesting because what they're saying is that the style that many women have in terms of leadership, which is kind of collaborative, let's get consensus on things, let's hear everybody's voice before making a decision, was seen often as weak. And yet we know from research that servant style leadership is actually more effective than top-down mandate leadership. In addition, they were kind of struck by the fact that there'd be this bias in terms of who was invited to be on the agenda for a panel or a conference. And often there were a number of, it was lopsided, let's put it that way. They introduced me to this term called manels, which is panels that are made only up of men. So seeing that bias and being kind of baffled that, the meeting planners didn't notice that. And also many of them mentioned feeling alone, feeling like they didn't have the energy, the time to connect with others. They thought that what they were struggling with in terms of getting their documentation finished, working for 2 hours every evening, trying to get their notes done, that they felt that they were the only ones struggling with that. And because of that, really felt like it was their fault. There was something they were doing wrong. When once they had some feedback that actually lots of people are experiencing this, it was a relief and a validation for them. Some additional observations. So this is more in terms of my experience over the past 5 years. I've done about 1,200 one-on-one hours of coaching with physicians, and the majority of them women. And so what I've seen is there's a tremendous increase over the past 3 years of the workload. And a piece of that is due to the second bullet there, loss of support staff. There are fewer nurses, there are fewer medical assistants. Often physicians are kind of required to step in and do some of that work, or work that would have been done by someone else to maybe call back patients and give them their normal results or things like that. There just isn't the staff. And so some of these things aren't done, or they're falling onto physicians in addition to their usual work. Values conflict, I think I've observed a lot of this, and it comes out in different ways. One of them is, again, going back to that productivity pressure. So many of the women in the interviews that I did and since talk about how important it is to give high quality care. They really want that. It is part of their value system. And when they feel squeezed by time, where they can't take the time to really think through an assessment and plan, or they can't take the time to talk with a patient and get a detailed history, or develop the relationship with a patient, they feel that. And it really affects their energy level, their motivation for work, their engagement. Again, the isolation. And lastly, fertility issues. Women physicians have an infertility rate of about 25%, and that is twice that of the general population. Now, a piece of that is that they are starting families later in general because of training, but that's not the whole story. And when you think about that additional stress of trying to go through infertility treatments with all the ultrasounds and blood tests and scheduled, appointments while you're either in training or early in your practice, that's an additional stress as well. So I want to now look at some of the data that's talking about what's going on underneath the surface that's driving some of this discrepancy or a disparity in the burnout rates. So in terms of gender bias, this is a really interesting study that was done back in 2017. And what they did was they looked back at recordings of grand round presentations. Now, these are presentations that are done usually once a week in a hospital and they might be the surgical grand rounds or the medical grand rounds, and an expert will come and speak about a particular, generally clinical topic. What they found when they looked back was there was a huge difference in whether the title of the person speaking was used when they were introduced. So all the way on the left, when women were introducing men, they almost always used the title, and that it would be doctor or professor or whatever. All the way on the right, when men were introducing women, it was only about 50% of the time. Now you might say, well, that's just, that was a mistake, or that, how much does that matter? But when you think about it, that either adds to or takes away from that person's expertise and their sense of from, or from others, that presentation of expertise. There's also a significant pay gap. It's been estimated about that it is about $2 million over the course of a physician's lifetime. There's also this idea of the motherhood penalty, which I mentioned before. And what's really, I think, fascinating is there is a difference in work tasks. So physicians who are men and physicians who are women are not doing all of the same tasks at the same level. And what I mean by that, it comes up in this next study. Now, this was a perspective article that was in New England Journal of Medicine in 23. And it looked at trying to get below the pay gap for primary care physicians. And what they talked about was that certain tasks that are really important, very valuable, were not being addressed or seen as worthy of compensation or seen as productive tasks. And as I mentioned, physicians are often paid based on the relative value units, which is a way of calculating the value of the time that they're spending, of the work that they're doing. And that often their pay is based on that, and potentially bonuses and other things. And if they're not hitting those targets, they hear about it. So what they found was that some of these, like I said, important, valuable tasks, like spending more time in conversation with patients, is not compensated. And so, for example, women physicians spend on average 2 minutes more per patient than their male colleagues. They also spend more time on the electronic health record. So for women physicians, they've estimated that for an 8-hour clinical day, they spend 7 hours on the electronic health record to enter their notes, to order labs, to order medication, to fill refills, all of that. Whereas there's about 7 hours for women physicians, about 5.2 for male physicians. So there's a difference there in the amount of time that they're spending. Now, in the exam room, they're also spending more time talking with patients who are asking about psychosocial issues. Now, addressing depression takes a lot longer than some of the other more straightforward physical questions that someone might have. So for all these reasons, there is this pay gap. This is part of the pay gap. Another aspect of this that relates, again, to the difference in work that's being done has to do with inbox messages. So these are messages that are coming either from patients through the patient portal to the physician or from the internal staff. And what they found is that women physicians receive more messages from patients. So that is the third column to the right, and more from staff. That's the first column on the left, the first most left column. And what I think is so fascinating about this is one of my clients that I worked with, she was in primary care, and she said to me, you know, we noticed in our clinic that when there was a kind of a urgent issue that came up, like maybe there was a patient who was 20 minutes late, can you fit them in? Or there's someone who's come and we don't have a space, or someone who needs to be seen today, can we double book them with you? Something like that. And what she said was, the medical assistants were always coming to the women in the practice, the women physicians. And finally, she asked the medical assistant, why are you not asking, our male colleagues? And the medical assistant said, because you respond. So there had been this kind of culture that had developed about who to go to with this extra work. Now, what they did was they developed a policy where those extra pieces of work were distributed, were triaged evenly to get to, kind of get to that problem and address that. But these are the kinds of kind of subtle cultural things that can happen that show up as more work for women. There's also the role expectations at home. Now, women, when some research has been done, comparing male and female physicians and what time they're spending at home. So those who have children, there's a pretty big difference between what each of them is spending in terms of hours. So women physicians are spending 8.5 hours more on average than their male colleagues on domestic tasks if they have children. They are also far more likely to have a partner who is working full-time, 85% to about 45%. So they are less likely to have someone who can stay home with the child, or who can pick up the laundry or the dry cleaning, or can take the car in. And so that's an additional kind of pressure and stress that they're carrying. They are also more likely to be the ones who cover childcare gaps. So if a child is sick, if suddenly daycare is not available, they cover about 45% of the time, whereas their male colleagues were only doing that about 12%. This was an article in Harvard Business Review in, I believe it was, 2022. And again, it was noticing women are leaving. Why? And they identified that there were lower scores in, this is based on different research that they compiled, but lower scores in 3 areas. Alignment. Now, alignment in their definition was the congruence between the values of the physician and those of the organizational leaders. And also whether there was kind of a more positive relationship between the physicians and administration. Resilience had to do with both this sense of, do I get meaning from my work? Am I able to feel that this is a meaningful profession? And also the ability to recharge after work. And finally, intent to stay, that women physicians were much more likely to indicate that they would be leaving that organization within the next 3 years than their male colleagues. So they had lower scores in all of these 3. So what do we do about this? I believe this is a public health crisis. And if you have tried to get an appointment with your primary care physician lately, you may agree with me. So there's a lack of availability, in part because so many have left the workforce. And that shows up as harder, it's more difficult to get those appointments, to get a same-day appointment, to even get an annual appointment, right? And so this is a public health crisis. Yes, it affected me personally to experience burnout. It affects other individual physicians, but it's a larger issue than that. And so we really do have to think about, what do we do? I want to start this conversation with this image. This is from the Robert Woods Johnson Foundation, and it's talking about this difference between equality and equity in terms of resources. So equality would be fairly distributing the same resources to everyone, regardless of their need. Whereas equity would be providing resources that are tailored to the needs of that person so that they can best contribute, so that they can work at their highest potential. So I want you to hold on to that idea while I present what I call the paradigm shift. Now, when I was in training, I had this sense that I was really out there on my own. Like if I wasn't doing well, I had to figure it out. If I had a question, I had to figure it out. There just was this sense that, yep, you're on your own, and I see that still with my clients, that so often they just need some support. They just need a leader to be interested in their career. And they are not getting that. That is not part of, in my experience, what I've seen, that is not part of the culture of medicine. Instead, what if we were to switch from that? What if we were to change that thought pattern and instead say, what do we need to do to retain women physicians? Now, ideally, we'd be saying, what do we need to do to help women physicians thrive, right? But let's start with retaining them. And interestingly, you could put any subpopulation in there. Like, what do we need to do to retain newly trained nurses? What do we need to do, right, to retain medical assistants? And thinking that way opens up all sorts of ideas for what we might do. But it takes us from it's their problem to we need to solve this because it's affecting everyone. And it affects an organization, a healthcare organization's bottom line. It costs $1 million to recruit and replace a physician. That's a lot of money that could be spent in shoring up some of the resources and support that individuals need to avoid burnout. So I want to move now to organizational strategies. So what might organizations think about that might reduce the risk of burnout and build careers where individuals can be healthy, happy, and can thrive? At the highest level, I think this requires creating a belonging culture. And I'll say a little bit more about that in a moment. I also think it requires really understanding what the local stressors are. So in this instance, we're talking about women physicians. The stressors on an anesthesiologist or a surgeon are going to be very different from those experienced by a primary care physician who is outpatient, 100% outpatient, right? If you are thinking about what they need, what those stressors are, they're going to be different. Their schedules are different. The lack of flexibility in schedules is different. And so really you need to go into those subunits, right? The clinical micro units, and find out what those stressors are. Now, that can be done. One of the best ways is to shadow, to have an executive leader shadow a clinician for a shift and see what does it take to order refills or to have a patient roomed quickly or to have the OR turnover, right? What are those system issues that are so frustrating and are exhausting people? And so that's one way of looking at those and finding those stressors. Others would be asking people, doing surveys, doing focus groups, but really finding out what those are. Don't assume that you know. And addressing the time pressure. So the article in the Harvard Business Review spent a lot of time talking about some of these aspects for addressing time pressure. One of the most important is ensuring that the electronic health record is efficient and that glitches are quickly identified, that there is an IT person available to come and sit with a clinician and walk through some of the issues or the inefficiencies and fix them. So often I hear that you can't get through to anybody. And it just makes that process of documentation take that much longer. Now, I mentioned creating a belonging culture. Adam Grant is a psychologist who has this podcast called the Work Life podcast. And one of his episodes was on how to build an anti-racist organization. And I really think it was really fascinating for not just anti-racism, but an inclusive and very productive culture. And this is what his guest said, right? So When an organizational leader allows uncivil behavior to continue without addressing it, that becomes the culture, that becomes acceptable. And this is where it is so important to have both the leadership really on board with addressing this and creating a place where everyone can contribute because they feel psychological safety and supported. Um, and and so I just think this is incredibly important as one of the things organizational leaders can do. The other piece is to provide training so that if someone observes an episode of a bias, that they can step in, that they know what to say. And next, I wanted to share some specific strategies. So one of them is really looking at what are the best options for the schedule for that individual physician. Now, often it's become more and more difficult to have that flexibility because health systems are joining together, merging larger and larger. Sometimes the scheduling is done kind of off-site somewhere. And so that person doing the scheduling is just using a template and they're putting the patients in, and there is no option for flexibility. But the more that the clinician can have some control over that, the better. Flexible and part-time options. There's a woman that I worked with, and she's in primary care, and she trained in the UK. And when I spoke with her, she said, you know, where I trained, when you came back from maternity leave, the organization approached you and said, what would work best for you at this point in your life? Do you want to just work weekends? Do you want to start later in the day? Do you want to share a position with someone? But they proactively came and asked, what's going to work best for you? I have not heard of that sort of thing happening in the US. Compensating for that invisible work. Now, I talked about some of it that's not being compensated for in terms of spending more time in conversation with patients. But another place where this shows up is being on some of these voluntary committees, like the Wellness Committee or the DEI, Diversity, Equity, Inclusion Committee, and having that be something that maybe it's work you love to do. It's important work, and yet it's not being compensated for. And so physicians are doing that work and then doing all the rest of their work. So it's adding on to the workload. One of the key drivers of burnout is having workload that is increased and then not having the resources to do that work. And finally, policies to support working moms. And I'll say a little bit about that in a moment. Now, these are just 3 specific strategies. There are many others, but I wanted to highlight these as just examples of some things to think about when we start asking that question, what do we need to do to retain women physicians? So a specific program that I learned about from those interviews that I did, one of the things that came up over and over and over again was the difficulty and the additional stress if you are nursing and a working physician. And I was really fascinated by that, how many times that came up. And so I wrote a blog post about it. And soon after that was put in touch with the folks at UCSF who had started a specific lactation support program for physicians. And here's what they did. They provided, and this part is focused on physicians in ambulatory care. So they would provide a half-hour break for pumping. They also provided clean pumping rooms and a reservation system. So you could say, I want to go at this particular time, and the room would be available. They also provided basically coverage. So those relative value units, meaning that that woman was not losing pay because she was taking that break. And the program was so well accepted by these employees. And when you think about it, this is not a long-term investment. Women are not going to spend the rest of their careers breastfeeding, and pumping. But to get them through that period of time, it is an investment. And I wrote about this in my blog if you're interested. Individual strategies. One of the things about burnout, and this came up, and I learned this over and over as we were writing the book, Preventing Physician Burnout, that burnout is a systems problem. It is about excessive stress in the workplace. It's a mismatch between the workload and the resources available to do it. It is not about individual susceptibility or individual weakness. At the same time, I have now seen over and over again as I've been coaching that when individuals can find the places where they do have some power and make some changes there, it has a huge impact on their daily work experience. And so it might be that the system is 99% of the problem, but if you can identify the 1%, that's the place where you can start. And I've seen over and over again how important that concept can be. So individual strategies. I believe that physicians have agency in 3 places: who we show up as every day, how effectively we lead. And physicians are leaders, even if they don't have a formal leadership title like medical director or CMO, chief medical officer. They are leading clinical teams. How they lead is important, and that is a place where they have power to model behavior, to communicate effectively. Finally, how effectively we advocate for change. In those places where physicians do not have the power to make a change of something that's inefficient or frustrating or potentially a patient safety issue, they can learn to more effectively advocate for change, to make those requests of the right person who is the decision maker and make it in a way that is more likely to end up in a yes. So I wanted to focus in on one of these places of agency because this is what I have learned as a coach. This is a place where coaching is incredibly helpful. So showing up as our best self. One of the things that I ask the clients that I work with is, what does your A game look like? When you are at your best, what does it look like? What's your energy level like? How do other people interact with you? And then I ask them, what are the preconditions that make it more likely that you will be on your A game? And the number one answer that I get 90% of the time is sleep. So initially they say, I can't do anything about that. I'm busy. You know, I'm at call, I've got kids. And we start small. We start small. So one of the issues can be self-sacrifice. I don't know if it's that we are, those of us drawn to medicine are ready to sacrifice ourselves, or if we learn it in training, but sometimes we can overdo it and therefore not be caring for ourselves. Creating those best self conditions. So once you ask the question, what are those preconditions? Can you take small steps to move that way? And learning to set boundaries. That is not easy for many of us. It's something you have to practice. But every time you say yes to something, you are saying no to something else. I might say, yes, okay, I'll do that one committee once a month. But if that means that on that day, I don't have the energy to be my best self with my kids or to do that yoga video that I want to do, then it has a cost. And I wanted to just quickly share one specific story about a client who made some very specific changes. So she is a primary care physician, had been practicing for 14 years. And when I started talking with her, she said, you know, I work part-time, technically 3 days a week, 0.6 FTE, and yet I am working every single day of the week. I work 7 days a week in order to get my notes done, the orders done, finish my charts, all of that. I just want one day off. And so she identified a couple things she might try. I had some suggestions, but she identified, try as an experiment in the next 2 weeks. And one of them was to change how she did pre-charting. So spending about 45 minutes the day before, going through all of the charts for the next day and just preparing. The other thing she did was set an intention of finishing her note before seeing the next patient. Not easy to do. But she decided she would try to increase the number of those that she did in the day. She came back 2 weeks later and she said, I had a Saturday off. And she has continued that. She now is about 80%, 90% finishing that note before the next patient, which means that she finishes with just a few charts to do at the end of the day. She can get home to be with her kids. She has 3 young kids, and she has a weekend. Huge difference with only small changes. And she said to me, I didn't think this would work. I really didn't think this would work. I can't believe I didn't try this 14 years ago. So again, just an example that these small places can make a difference. I hope that you will take away from this conversation today. All physicians are facing a lot of stress today. Our healthcare system is not in the best condition. It is really stressful. And yet there are certain subgroups that have some additional challenges. And we can see underneath from this data what's driving some of those gender-specific challenges. And I hope you walk away with the hope that there are strategies, both at the organization and individual level, that can help reduce the risk of burnout. I want to thank you for being here tonight. This is a topic that I'm incredibly passionate about, and I hope that you take something away from this, including hope about what we can do together. The QR code goes to my LinkedIn profile. I'd love to hear from you and love to connect, or you can connect with me through my website. I also would love to let you know that I just started a podcast 2 weeks ago, Vital Signs: Thriving as a Woman in Medicine. And I would love to hear what you think of it. Each episode, I talk with either a woman in medicine or an expert about what is going on, what are those challenges, and what can we do about it. So I will stop there and turn it back over to Wendy. Thank you so much for your attention.